So, 41-year-old female with no previous known comorbidities was presented to ER with the chief complaints of left-sided neck swelling since 1 week and fever since 1 week, then dry cough since 4 days, then vomiting since 2 days, and rash since 1 day.
Okay.
So she was like 1 week back, she started having a neck pain on the left side. Then it is she noticed that there is some swelling on that side. On pressing, there was some tenderness also, and then it gradually increased in the size for like 2-3 days, and at the same time she developed fever also. Fever initially was high grade only, but on taking medication it was subsiding. But in last 2-3 days her fever was not getting subsided even with the medication, so she consulted a doctor online consultation she took, and they thought it is like she was having dry cough and fever. Thinking URTA, asked to start augmentin, and when she took augmentin tablet, she's feeling nausea, vomiting. She has 2 episodes of non-projectile vomiting containing food and water. Then by evening she started having some amount of redness over the face and all that, and over the upper part of the chest.
What is the typical feature of IMN, infectious mononucleosis?
Sir,
What is a typical feature of IMN?
augmentin.
You tell me the typical feature of IMN. What is IMN?
Infectious mononucleosis.
Okay, what virus?
Epstein-Barr virus.
Okay. How do they present?
Usually will present as
Kissing disease. What is that? Patients will
It's
have
a
high degree
medical-
fever. Patients will have cervical lymphadenopathy.
lymphadenopathy.
After taking amoxicillin,
They will develop a maculopapular rash.
that is a typical feature of IMN. Okay, so you should keep in mind that in cases with high degree fever, cervical adenopathy, avoid amoxicillin. Okay, you can give some other drug like doxycycline, azithromycin. All have similar effects. Amoxicillin, the problem is patients who can develop severe rashes. Now we don't know whether the rash is a part of the disease or part of the drug. Okay, that doesn't mean that this drug is allergic. The patient is not allergic to actually amoxicillin. Only part of this disease is developing the rashes. Okay.
So
Can you explain the rash little more? What is the type of rash? Is the rash is present only during fever, or fever subsides? Fever persists after fever episode.
like fever was persistent, fever was not subsiding, and the rash start appearing at the same point of time. And rashing was means initially only face, then start appearing on neck and chest, and it
Because
was
other
increasing.
than viral rashes, everyone know that they come, they persist, they subside after 1 week. As a postgraduate, you should know something more. Like one is this infectious mononucleosis, other one is adult onset Still's disease. How do they present?
She also has associated joint pain history.
Adult onset Still's disease, in terms of this rash, how do they present?
They will have the salmon color.
Salmon color is red color.
Red color rash.
These all rashes are red color.
And the rash, they will have associated arthritis.
That doesn't. It is not compulsory to have arthritis and adult onset Still's disease. That can occur much earlier of the disease. What is a typical feature of this rash in adult onset Still's disease? What is a typical feature? You all finished entrance recently, that's why I'm asking repeatedly. Salmon color rash is okay, but all rashes are actually salmon color, only red color. They present during fever episode. After fever subsides, they disappear. That is a typical feature of adult onset Still's disease. Okay, so what you are going to present is a case of HLH. That's why I'm telling. This adult onset Still's disease, infectious mononucleosis, they are similar to HLH in all clinical features. So this can be adult onset still disease also. Okay, that's why I'm telling. So rashes are very important. If fever, during fever, if this rash is occurring, then you have to think about adult onset Still's disease. That can be a part of rheumatological disease. That can be part of malignancy. That can be part of without any other disease. Okay.
So along with this, she is also having a history of travel. In last like 3 weeks back, she traveled in jungle for trekking, and she is also having like no contact, no cause contact, and no history of any loose stools, vomiting, photophobia, dysuria, or decreased urine output, and no history of any chest pain. Then there is no similar complaints in the past. This was the first episode she presented. And personal history, she has a little bit of reduced appetite last these days. Otherwise, her appetite previously was normal. No history of any weight loss. And bowel bladder is normal. Sleep is...
Why appetite is reduced in all types of fever? Since you are a medicine PG, I am asking. For emergency medicine PG, we never ask. Why? What is the reason? You see all patients who come here, little lack of appetite. What is the reason?
Inflammatory states. It can cause gastric irritation.
No. Then you will have only gastric irritation. No? There is something to do with the satiety center. So you have to read about what is this inflammatory marker will do to your satiety center to reduce the appetite. Okay, so that's why that is one of the earliest sign of any inflammation, infection, and that will be one of the earliest sign to come back. So if the patient recovers, immediately patient will start taking fits. That's why whenever we take rounds, we are asking how is the appetite. So if appetite is coming back, means patient is recovering from the disease. Okay.
Then sir, otherwise drug history was only that Augmentin intake. Other than that, she is not taking any other medication.
Okay.
So, and then she presented here on initial lab investigation we have done. On that, we found that her WBC count was actually on little lower side.
How much?
4,000 with neutrophilic predominance.
Okay.
And HB was also normal initially. It was 12.8. And platelet count was on little lower side, 120,000.
Okay.
It's more towards a viral picture.
Okay.
And then inflammatory markers, CRP was 223, Procal was negative, and ESR was 63. And then urine routine was also normal. There was no any signs of infection. Then her RFT, urea was 17, creat was 0.7.
Okay. Why urea is elevated?
Urea is
70 is not 17. Okay.
177.
Okay.
Then bilirubin was elevated, and which was direct type, like 2.62.
Direct.
1.9 is a direct.
Okay.
And then AG ratio was normal. Albumin was 3.9, globulin 3.6, and OTPT was also elevated. It was like more than 3 times, 193 and 278.
Okay.
And alkaline phosphatase was also on the higher side, 223.
Okay. What is the significant elevation of alkaline phosphatase in clinical medicine?
More than 2 times.
More than 3-fold. SGOT, SGPT, alkaline phosphatase, all if they are more than 3-fold, then they are significantly elevated. Otherwise, they are elevated, but that doesn't correlate with your clinical medicine. But if it is more than, then you have to strongly suspect some reason for that.
Then sir, other inflammatory markers like ferritin was also done suspecting the HLH. And
how much?
25,000. 25,000 and LDH was also done. LDH was 1,200.
1,200, okay.
And then fibrinogen was done.
What is that lymph node? How is a lymph node now?
Swelling
is still persisting or not?
On examination, sir, I actually vitals. On initial presentation also, she has the blood pressure was normal, pulse was 102, and temperature was 100.2 Fahrenheit. And there was a presentation of macular rash over the face, neck, upper part of chest and back. And lymph nodes were palpable, more on the left side as compared to right side. Right side also, multiple lymph nodes were palpable.
Multiple means they are discrete?
Multiple discrete lymph nodes with the dimension of maximum dimension of 2 by 1.5 centimeter, mobile, tender.
Okay. Is there any other lymph nodes? Axillary nodes?
Axillary lymph nodes were not palpable. Axillary and inguinal.
Spleen, liver?
And then liver was palpable, 2 fingers below the costal margin.
Okay. Spleen?
Spleen was not palpable clinically. But further we evaluated with ultrasonography, showed hepatosplenomegaly.
Okay.
Then further triglycerides were also sent, and that was 468.
468.
It's more suggestive of HLH.
Okay.
So for further evaluation of HLH, autoimmune workup was also sent, and ANA was sent, and that was 1+.
Mm-hmm.
And then for to rule out the infective causes.
Tell me something about ANA. You are telling it is positive.
It's fine speckled 1+, means it's a borderline positivity. You cannot.
That means she is having SLE.
Can be a cross reactivity also 1+.
Many viral infections it can be positive. Normal person 30% it can be positive. Malignancies it can be positive. It's a highly non-specific test. Okay, you cannot do an and tell that this patient is having an immunological reaction. It can be something else also.
But the blot was sent, but it was
okay.
Then her clotting profile, PTNR was 0.93 and the APTT was 36.7. Fibrinogen was elevated, sir, 423.
Elevated? Not reduced?
Not reduced.
Initial HLH, what is according to criteria?
Less than 150 it should be.
It has to be reduced. This is only an inflammatory marker. This fibrinogen is an acute phase reactant. So any inflammation it can be elevated, whereas in HLH it will be reduced because the PTNR will be increased, APTT will be increased, and fibrinogen will be reduced. Okay. So
for this, she was initially started on empirical.
You are still not considering adult onset cell disease. You are not considering infectious mononucleosis.
Yes, sir. Further, for the evaluation part, workup was
you cannot have single diagnosis. You cannot tell it is HLH. HLH ideally it has to be very causes. High. It has to be 50,000, more than 50,000. Any of the patients will have adult onset cell disease or what is it, infectious mononucleosis, dengue. You can get very high ferritin. Ferritin is only an acute phase reactant. But very high levels, more than 50,000, 90,000, always goes in favor of HLH. And here hypofibrinogenemia is not there. And triglycerides are not very high. When did you take the triglyceride in this patient?
It was fasting only.
Morning. It was fasting. Okay. So that is slightly elevated. Platelets are not.
Platelets was 1 lakh.
But only 1 lakh 20 is normal. And the counts are only 4,000. It is not very low. It is low, but it is not very low.
So for further confirmation and to evaluate for the blood malignancies also considering as a cause of HLH, bone marrow aspiration and biopsy was done.
Okay.
Which shows mainly that...
anything else you could have done before that? Bone marrow aspiration is a very invasive, painful
before
procedure.
that,
you have to do ideally, you have to do it to diagnose HLH. But what about the lymph node?
AUSG neck was...
No. Did you do FNAC of lymph node or biopsy of lymph node?
No, sir. Biopsy of the lymph node was not done.
Why it is not done?
Actually, patient was not willing.
Not willing. Okay. But when you are seeing a lymph node like this, what is the differential diagnosis you can have in this patient? If you are suspecting HLH, what is the differential diagnosis? If you are not suspecting, what is the differential diagnosis? If you are suspecting HLH, lymphoma is the most common thing which can have both lymph nodes like this and HLH. Okay.
So lymphoma and EB.
In that lymph node, which type of lymph node?
It will be very hard form.
That means which organism is behind which can produce both lymphoma and HLH?
Epstein-Barr virus.
Epstein-Barr virus. That can produce all these problems. That's why I'm telling. Okay.
Epstein-Barr virus. So for EBV also we evaluated.
Okay.
We have sent the IgG and IgM
There is
antibody. No, sir. Actually, initially it comes equivocal result for IgM.
Okay.
And IgG result was awaited. Then it came little later. Till that time, we are evaluating for the other causes as well.
Which is more significant, IgM or IgG?
IgM is for the acute reaction, and the IgG is chronic.
Long term. Okay. So that is still a possibility. Okay.
And then other for the other infective causes for
X-ray, chest X-ray.
Chest X-ray was done, and it was within normal limits only. No significant hilar lymphadenopathy.
Ultrasound, no pleural ascites.
Ascites was not there.
No
only
other
hepatitis, no features suggestive of malignancy.
Nothing is there.
Not there.
Okay.
Then further we have sent for this. She has that cat history also and travel history also.
Okay.
So for that scrub was also sent as one of the thing. Scrub typhus and leptospirosis also was sent, but both came negative. And for the malignancy evaluation, PET scan was also planned.
And bone marrow, what happened?
And bone marrow, sir, bone marrow was done initially, and that showed tri-lineage maturation with feature suggestive of HLH. Hemophagocytosis was there, but no feature suggesting lymphoma or leukemia was there. So for further evaluation, any other malignancies, also the PET scan was planned. But that shows only increased uptake significantly in bone marrow and spleen, which is again suggesting towards HLH only, with the reactive lymph nodes in the bilaterally.
Okay. So what is your final diagnosis from all these things?
And then IgG level also came by that time, and it was elevated. So it was 600.
Which IgG?
IgG EBV.
Okay.
Antibody for EBV came positive, and it was 600. It was much higher.
So what is your final diagnosis here?
Final diagnosis was EBV induced.
So Epstein-Barr virus, that is infectious mononucleus. Induced dysregulated immune reaction. Okay. HLH means patient has to be very sick. Here, theoretically HLH only, but patient is not that sick and ferritin is not very high. Hypofibrinogenemia is not there. Multi-organ dysfunction syndrome is not there. So it may be a partial HLH, that's all. It is not a full-blown HLH. Okay. Now, what treatment do we have to give for this patient?
Sir, we have to pulse the patient with steroids.
What steroid do you prefer?
Methylprednisolone or dexamethasone.
Okay. What is the difference of these two? How do they differ?
Dosing we have to calculate.
What is the dose of dexamethasone in this type of conditions?
It will be around 40 mg.
40 mg. 40 mg IV. Methylprednisolone?
It will be 1 gram.
1 gram into 3 days.
3 to 5 days.
Okay. Which drug better penetrate to CNS?
Dexamethasone.
So that's why dexamethasone is always a better drug than any other steroid, because that has got a good penetration to CNS and that has got some more advantage. Fluid retention, which is better?
Dexamethasone will have less fluid retention.
So in patients who is having CNS manifestation, dexamethasone is always better. But even methylprednisolone also can cross the blood-brain barrier, but not like dexamethasone. That's all. Okay, and cost, which is costly?
Methylprednisolone.
That is costly. Dexamethasone is very cheap. Okay, so you have started
pulsing with dexamethasone.
Okay, 40 milligram.
It was 8 mg Q6 hourly was given for period of 5 days.
Okay, and what is the ideal dose of dexamethasone in highly inflammatory condition? Is it TID or once daily? What is the advantage of giving once daily? What is the advantage of giving disadvantage of giving 3 times daily? There is only one disadvantage. What is the disadvantage?
It will.
What is the disadvantage? You are giving it as an anti-inflammatory action. You are not replacing steroid in your body. Steroid has to be produced from your body like a normal steroid production. For that, you should not give evening dose of IV steroid. If you are giving evening dose of IV steroid, urine steroid production will be reduced. Okay, to avoid that, you have to give a morning dose of steroids. High dose can be whatever dose, like you are giving 8 milligram TID, so 24 or 30 milligram, you can give in the morning itself. That gives a good immune suppression than giving TID, and it will not suppress your own steroid production. So all and inflammatory conditions, steroid should be given as a single. That's why we call it as pulse therapy. TID is not pulse therapy. Okay, TID is a replacement dose. Where will you use that?
Mostly in Addison's disease or
Addison disease, we can give that. In emergency, where will you give TID or QID or continuous infusion? Septic shock. It is given in a shock patient. You have to give either a continuous infusion or at least 6th hourly 4 times you have to give. In that type of condition, all inflammatory condition like this, you have to give a bolus. That's why we call it as a pulse therapy. Okay, TID can be helpful, but not like your bolus dose. Okay, then what happened to the patient? So whether it is adult onset Still's disease or infectious mononucleus induced HLH or real HLH due to conditions like primary conditions like malignancy, rheumatoid arthritis, all these things, steroids are the first line treatment. What happened to the patient?
Then patients start improving after that, like her fever totally subsided, joint pain also reduced, and then appetite improved. She was taking well, and then she was continued with this same dose for around 2 weeks, and then planned for the tapering further.
How many days you have to give pulse therapy?
Pulse therapy 3 to 5 days is
maximum 3 days is enough. Then what you do?
We'll taper the dose.
Taper dose means you are giving methylprednisolone 1 gram into 3 days. Then what you do?
Then 2-3 mg per kg.
3 mg means 2 or 3. 2 or 3. 1 to 2 mg is the dose to be continued. 2 mg means 70 kg. You have to give 140 milligram of prednisolone. Okay, that much you have to give. Okay.
That will be given for 2 weeks. Then fully totally taper till 8 weeks.
Okay. How many days you require to taper the steroid? Like suppose I am giving for an asthma patient 1 week, 80 milligram steroid for 1 week. Should I taper and stop or
less than 7 days? Even if the high doses are given, no need.
So if you are giving for 5 days or 6 days, there is no need to taper. More than 2 weeks, if you are continuing, then better to taper. That too, when you are giving steroid, that should be given only morning time, not in the evening time. Evening time, if you are giving, then it will suppress your steroid production and it can produce long-term side effects. Okay, so you have started steroids, and what happened to the patient?
A patient actually improved. All the symptoms was subsided.
Okay.
And then patient was put on the maintenance dose.
Okay.
For that, and patient got discharged.
Okay. Any other problem she had during the
hospitalization? No other
problem. All malignancy, rheumatology conditions, all these things ruled out.
Ruled out, sir.
Okay. So what you understood from this case? There are few important things an emergency doctor should understand from this case. One is what? First one is what? First one. Avoid drugs like amoxicillin when the patient is having acute onset of viral illness. Okay, amoxicillin is not a drug for viral illness. Okay, should never start it. Should have been never given to the patient. Okay, that's why this patient has developed all these complications. Okay, so we should avoid amoxicillin in a patient who is having suspected viral fever, especially when there is cervical lymphadenoma. I am not telling amoxicillin has induced HLH. HLH is a part of this disease. Okay, second thing is
EBV.
EBV can produce HLH. HLH diagnostic criteria is?
Sir, 5 out of 9 criteria.
Okay.
Should be there.
What are the criteria?
To diagnose the HLH.
Some tests we cannot do here, like NK cells and ILs we cannot do.
IL-2.
IL-25 we are doing, but other tests we cannot do. What are the criteria?
Fever more than 38.5 degrees Celsius, and with the splenomegaly, and with the peripheral smear showing cytopenias at least 2 lines. HB should be less than 9 gram per deciliter. Platelet count less than 1 lakh, and absolute neutrophil count less than 1000.
Is hemoglobin drops because of what?
hemolysis occurring during because of the hemophagocytosis. And then hypertriglyceridemia more than 265, then hypofibrinogenemia less than 150, and then bone marrow, spleen or lymph node lever feature suggesting of HLH, then low or absent NK cell activity, and ferritin more than 500 but more suggestive when it is more than 3000, and then elevated CX.
We see dengue fever patient, now most of them will have high ferritin level, so
but
that doesn't mean that they have HLH. Most of the real HLH patients will have more than 50,000.
And then elevated CD25 and interleukin 2 receptor.
Okay. So at least 5 should be positive.
Positive out of 9.
How many of them are positive in this patient?
These patients are 4 was positive.
Which one?
Like the HLH feature.
This one, nothing was positive. Ferritin was
fever was there, sir. Splenomegaly was there. Hypertriglyceridemia was there.
Okay.
And hyperferritinemia was there.
Then?
Fibrinogen and the HLH activity was there.
In bone marrow.
Bone marrow.
So it's a partial HLH only, but patient has recovered very fast from the problem. Okay, some patients you can see multi-organ dysfunction syndrome also associated with this. Okay, so many cases of like severe sepsis, what you are seeing in your practice may be actually HLH. Okay, what is this HLH?
It's a hemophagocytic lymphocyte.
That I understood. What is that?
It is a monocytes in the blood get in the tissue. Macrophages start having the phagocytosis of the erythropoiesis.
One word for this, all these phenomena. Immune dysregulation. All these things are immune dysregulation syndromes. Okay, actually they are activated to kill something, but they are dysregulatedly and the numbers are elevated and they try to kill your own cells. So immune dysregulation syndrome includes this one, adult onset Still's disease, so many things can, multi-organ dysfunction. All syndromes are due to this only, immune dysregulation syndrome.
Cytokine storms.
Cytokine storm mean what? Same thing only.
The level of all cytokines, interleukins.
Macrophage activation syndrome is what?
Interleukin 6.
This is same, but that is basically used for rheumatological disorders. Okay, this is used for, it's a general term. Under that umbrella, lot of things come. Okay, here it is only due to the virus, Epstein-Barr virus. Anything else you want to add? Nothing. Okay. Anything else you want to add?
Criteria for MAS is little like 2 clinical and 2 laboratory criteria to define out of 4 from both.
And treatment, anything else is given in guidelines other than steroids?
Sir, like other immunosuppressing agents can also use also like
infliximab,
etoposide plus dexamethasone or cyclosporin.
All drugs can be utilized.
Or even IVIG.
IVIG can be used. Okay. Thank you.